Hey Ray, welcome back to another casual conversation, Association of the Cannabinoid Specialists. I'm your host, John Malanca, with my colleagues, Dr. Jordan Tishler, as well as Dr. Adam Abodeely. Good to see you guys.
Hey, good to see you.
So here's another question that came in, and it comes in quite a bit. The importance of route administration. There's so many different types of administration of this. So, Dr. Tishler, you want to touch up on this one?
I've always been impressed that human beings, being ingenious as they are, um, have taken cannabis where it's never gone before. And essentially, if a human being has a surface or a hole, there's somebody who's figured out how to stuff weed in there. So really the question then becomes, with all of these various products that you can stick wherever, which ones of them are actually useful, and for what? And I think we have a lot of information about things like uh, the lack of transdermal absorption. Similarly, a lack of what we call transmucosal or through the mouth lining kind of absorption. And, we know that there are lots and lots of products out there that claim, for example, topical creams or tinctures to be effective that way. And, they're relatively harmless in that regard, but they're expensive. And as a physician, I tend to view the cost to my patient as a potential harm. So when I'm thinking about route of administration, I tend to think in terms of um, inhalation as one form, um, which is rapid onset, really
Yep.
starts in sort of 10-ish minutes, but relatively short in duration, 3, 4 hours, something like that, which makes it good for some sorts of problems, but not so good for others. And then we have oral administration, edibles and the like, which are delayed onset because they get absorbed and actually metabolized by the liver into a new chemical, not delta 9. We put delta 9 in, we get 11 hydroxy THC out, and that works for longer. So that's better for sort of chronic problems like pain and that sort of thing.
You know, a sublingual oil or tincture versus a gummy or a transdermal patch. What are your thoughts on that?
We've got data outside of the jazz pharmaceutical
Yeah.
environment, right? That shows that sort of garden variety tinctures, which are some sort of an oil, usually coconut or something like that, with cannabis in it, don't readily get absorbed sublingually. So people will put the stuff under their tongue and they will perceive changes to the sensorium, right? But that's actually a psychological phenomenon because if we actually draw their blood at that point, we have studies that show the blood doesn't have any cannabis in it. When you,
Really?
yeah, but when you swallow it, then it gets absorbed normally as the edible would, and that's also effective. But from my point of view, if we're going to be using something that works because it's absorbed in the GI tract, then I would rather have somebody use a gummy because you know how much is in it, right? If you have a 5 milligram THC gummy and you swallow it, the question isn't how much you got, it's did you take it or not, right? And a lot of patients come to me and they say, "Oh, doc, I'm using a tincture." I say, "Great, what's your dose?" And then they say, "A squirt." And at that point, it's very hard to know what they're getting and how to help them because a lot of that revolves around dose. And the labels, which we will talk about in another episode, are very hard to understand. And things like concentration, how many milligrams of THC is there in a milliliter of oil?
It's still
Those
confusing
are-
for me. It's still confusing me. Adam, I know we've done all the talking here, and you not only located in Florida, but also your position up in New York. What's your take on that?
Well, there's a lot. Obviously, there's a lot to unpack on this topic. The
Yeah.
route of administration is definitely one of the biggest complexities I think that we face as cannabis providers because of the just the sheer complexity and the options. To touch on something that Jordan said, I certainly agree that the topicals. He's right. There's very little science, if any, to support transdermal penetration of this. It's given the nature, it's a lipophilic agent, and it's a very hard barrier for the skin to penetrate. And when you look at topical medications, if you go into drugstores, if you get anything prescription strength, the majority of them have skin permeating enhancers in them, which will help, for deeper penetration into the skin. And it's for this exact reason. We know that most medicines are not readily absorbed, particularly cannabinoids are not readily absorbed through the hydrous, waterous layer of our skin. So, I do believe that, it's different when we're talking about topical, applications for, maybe, some form of inflammatory condition, or, we're talking about using, cannabis topicals on burn wounds and all sorts of things. I think that's a very different animal. And I do think that, there is, although we need more science, I do believe there is probably some benefit to, topical, cannabinoid applications in particular instances, but the likelihood, if someone's trying to use a topical CBD or THC infused ointment on their knee for their knee pain, well, it's very unlikely those cannabinoids are going to make it through the skin, through the subcutaneous tissue fat, and into the intra-articular joint. So, I definitely want to echo that and emphasize that. With regards to the other forms we're talking about, when the sublingual, again, I agree 100% with Jordan. Again, a lot of the tincture preparations that people are accustomed to using with herbal botanicals are in denatured alcohol and other things that allow for better submucosal penetration. And as Jordan rightly pointed out, the majority of sublingual preparations are nothing more than a carrier oil with the cannabis oil. So there's very little evidence to suggest that any of that. So when I talk to patients about sublinguals, which some of them still prefer over, I just make them aware of the fact that it's going to act a lot more like an oral medication than it will an inhalational or the proposed sublingual, which is supposed to take effect quicker than inhalational, but maybe not as quick as I'm sorry, not as quick as inhalational, but quicker than oral. So I tell people that because what they do is they put it under their tongue, they let it sit as long as they can, and then they swallow it. So it's essentially inedible at that stage of the game.
At the Association of Cannabinoid Specialists, we are on a mission to train healthcare providers using research-backed science and to advocate for delivery systems that better serve patient care. Our children need us, and our parents do too. Help ACS bring care and relief to all who need it. Donate to ACS today.
There are a few things I'll share with the audience about oral administration is unique really to my patient population, and that is the treatment in patients with GI conditions like inflammatory bowel disease or motility disorders. I find it particularly challenging starting cannabis naive patients on oral preparations when they come to me for things like inflammatory bowel disease. So what do we know about patients with inflammatory bowel disease? Well, when it comes to their GI tract and their absorption, well, we know that they can have altered gastric emptying. Whether it's inflamed or whether it's not inflamed, we know that some patients with IBD have delayed gastric emptying, and if a medication sits in the stomach, it's getting the cannabinoids are very highly sensitive to pH. And so, as they're sitting in the stomach, a large portion of those cannabinoids can become, degraded over time. The other thing with inflammatory bowel disease patients is the increased motility, the diarrhea that they experience. And I can't tell you how many phone calls I get with people saying that they see their IBD capsules and medications in the toilet. They just poop them out.
Oh, wow.
Some pills are actually designed to do that. They're actually designed to keep their outer shell, and they release But I know that there's several that aren't, so certainly there's people with diarrheal conditions that it's hard for me to really understand. I mean, I can recommend any dose, but it's hard for me to understand how much of that, how many milligrams they're really absorbing. The same thing with these patients is that their microbiome is in disarray, in inflamed conditions, and we know that this has an effect on how different drugs, including the cannabinoids, are metabolized under different microbiome conditions. And then, also to that point, a lot of my patients have had our they've had surgery, and a lot of them suffer from short gut syndrome. They have ileostomies. So dosing these patients orally can be extremely challenging, and for that reason, I tend to steer people who are cannabis naive, particularly if if they have active inflammation. I try to steer them towards an inhalational route. I don't mandate it. It's just something for the same reasons I'm describing to you, that it may be hard to determine the effectiveness of it, that I explain that same thing to my patients. And as much as I'm not as much as I would prefer to say that everybody could just take a pill or a gummy, as it's probably one of the safer routes, that with this population's a little bit different with inflammatory states. And I also happen to treat a large population of gastroparetics, people who have gastroparesis. And what's interesting about that is that we know that THC and the cannabinoids can actually slow down GI motility. And so we would expect that, that could make gastroparesis worse. Which it probably does from an emptying study, but from a symptomatic standpoint, a lot of patients with gastroparesis have success with it. And there was actually a study that came out not too long ago that I think pointed, towards this finding as well. And gastroparesis, when the stomach doesn't empty, it triggers nausea and vomiting. So I don't think that it's doing anything for motility, but it's certainly affecting the nausea response in these patients, in a large percentage of these patients. So, the GI patients I find to be some of the most challenging to treat with this, particularly if they want to go the oral route for that reason. But having said that, I would really love to think and to have some evidence that if you take an inflamed small bowel or colon and you apply an oral medication, that direct effect might have a mucosal healing effect as well. And that, unfortunately, we don't have great evidence of, at least when it comes to clinical studies in IBD. That's why we see in a lot of IBD studies that symptoms are improved, but inflammation isn't always improved. And unfortunately, those studies are all over the place when it comes to, some are inhaling, some are taking oral, so it just points to the fact that, we really need some more and better science on this. And again, for that reason, I think that it's why I tend to steer people towards inhalational, at least until I can get their disease or their symptoms a little better under control, because I feel pretty confident that systemically I can do that with inhalational. But once I can get them into a better place, and then they just want more maintenance, then I'll typically encourage them or recommend that they try an oral medication. As Jordan mentioned, they tend to last longer. And if the goal is to control, symptoms of GI distress, abdominal pain, bloating, diarrhea, these things, well, those things tend to be continuous. So if we can give them some prolonged relief with an oral medication, and would definitely be the preferred route. As Jordan mentioned, the 11-hydroxy THC is a very potent compound, and it's nice if we can take advantage of that when we can.
One thing, so I thought I heard you say, because most doctors would not direct their patients to go with inhalation at first, just because of a lot of elderly patients are like, no, 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 but I'll take it in a sublingual form, meaning gummy or tincture. So it was interesting to hear you say that. One thing that hasn't come up, which has been discussed for the last 10, 15 years in this industry, is vaginal and rectal suppositories. What's your take on that?
Yeah, so as Jordan mentioned, I've met people who've put it in their ears, their anuses, their vaginas, their belly buttons, you name it, where there's a hole, they've been putting cannabis and they all claim that it has great effects. Putting what we do know is that the vaginal mucosa is not great at absorption of these for the similar reasons we talked about with the skin. The rectal, there is some reasonable absorption with that, and there have been studies that have shown that if you combine THC with a carrier molecule, that you can get even better absorption, but then it goes down more of the kind of pharmaceutical grade kind of compounds. But what I found is most people are much more willing to take an edible, inhale before using suppositories. There are several that
Yeah.
that would use it, and I've actually worked with patients on who wanted to make their own suppositories, and I've taught them how to make a suppository and all that type of stuff. But commercially, I think the reason that they're not available or people aren't really taking advantage of this route is just because there's not a critical mass.
I think that there are a couple other issues I'd add to that. I mean, everything you said is spot on, of course. When I first started my practice, people kept talking about suppositories, and in particular, um, for this idea that if you had prostate cancer, you should use an anal suppository. So I actually ended up developing some suppositories, and one of the advantages of a rectal suppository is that it bypasses that first pass metabolism. So instead of thinking of a rectal suppository as being equivalent to a gummy, it's actually more equivalent to inhalation. On the other hand, to what Adam was saying is like, it's fairly rare that somebody would rather stick a suppository up their bum than take a puff on a vaporizer. So the use case kind of became less. And in particular, the idea of a rectal suppository for prostate cancer or a vaginal suppository for, say, endometriosis really doesn't reflect an accurate understanding of the physiology. The idea that you put the cannabis sort of near the problematic area, it just doesn't actually work. That in fact, the way our bodies work is that the rectum, or to a lesser degree, the vagina, would absorb those chemicals and circulate them all throughout our body before they get back to either the uterus or to the prostate. And so the nearness factor sort of makes colloquial sense, but not physiologic sense. The one thing I will say about tinctures as a use case is it's very hard to put a gummy down a G or J tube, right? So if you have a patient who can't take anything by mouth, right, and you want to give them that long-acting form, then you can give them the tincture down the J tube, and that works if you flush it with tube feed.
On that, before you do that, and I know we're coming to the end here, I've worked with families, and can you talk about the carrier oil or the alcohol in the sublingual tincture of what you should avoid? So can you touch that, please?
Well, so it's interesting. Most of the really compelling data we have, again, is from the pharmaceutical side, and that's
Yeah.
really GW or now Jazz. And the reason their oral mucosal sprays work is that they have figured out that as carrier oils go, sesame oil, of all things, turns out to be the very best carrier or oil for providing bioavailability. And there was a study that came out this week that confirmed that yet again. But getting the oil to carry the cannabinoids is only part of the issue, as Adam was saying. Then you also need to get it to go across the membranes in our mouth. And we have to realize that from a biological and evolutionary point of view, our mouths are not designed to absorb things, right? And in fact, as part of our bodily defense systems, our mouths are designed to exclude things, right? Bacteria, we all have bacteria in our mouth, and most of the time, unless we're doing something crazy dental, the bacteria stay in our mouth and they don't get into us. And so our body is built to defend against those sorts of things. And so the alcohols come into the picture. When you mix that with the cannabinoids and the sesame oil, what it does is it irritates the lining of your mouth and creates openings in that otherwise intact wall of membrane. And so that does, in fact, allow the cannabinoids to pass into the bloodstream. But if you look at the GW studies, the number one reason that people withdrew from the study was because they got sore mouth, because now you're roughing it up with all this alcohol.
Yeah.
So, again, it becomes a question of sort of what do you need in order to make this work, and what is the optimal treatment for the patient. And I think, if you're looking for something that behaves like inhalation, a pharma grade tincture will get you most of the way there. But the question is, what is the downside to that versus the downside to, sticking with the inhalation? I don't typically recommend that people smoke, but if they're going to use a good quality flower vaporizer that has appropriate temperature control, all of the data suggests that we're getting the cannabinoids and none of the carcinogens. So at that point, we're looking at a fairly safe methodology, and I can't argue with it.
Well said. Well said. So, well, I know this conversation about the importance of route administration could go numerous ways. And so I appreciate your knowledge and your expertise on this. And my advice to our listeners, consult with a medical professional for yourself or your patients. And don't be afraid to ask questions. Cannabis is not a one size fits all, and neither is the route administration for you or your patients. So, love for you to join us at the Association of Cannabinoid Specialists, and we'll see you at our next casual conversation. Thank you very much. We'll see you then. Bye bye.